All right, this lecture is going to be on a pulmonary embolism, also known as a PE. And what a pulmonary embolism is, it's actually an obstruction of the pulmonary arterial bed that occurs by a dislodged thrombus or a clot or a foreign substance. So you can also get something in there called a pulmonary infarct or a lung infarct, where you have lung tissue death from this pulmonary embolus. It's sometimes mild and may not produce any symptoms. However, when you have a massive embolism that occurs involving especially more than 50% of an obstruction or of the pulmonary arterial circulation, it can be rapidly fatal. And so, for that reason, this can be a medical emergency because what we have going on here is you have a problem with ventilation, which I talked about in class, being the actual um, inhale and exhale part of the breathing cycle. Perfusion means that circulation is not getting where it needs to, and as a result, you get this mismatch. It leads to impaired gas exchange, and that's where that infarct occurs because we know that if you don't get oxygen and blood where it needs to go, you have tissue death, and that's where that lung infarct occurs. So here, this is kind of a difficult picture to see, but what I've got you looking at here is I've got you looking at the actual pulmonary circulation. And in the enlarged picture down at the bottom, you can see where that actual clot is. And so again, if blood and oxygen can't get where it needs to go, and you can see from this picture right here that there's very little space for any blood to get through, you're going to have a problem, and that's where that infarct is going to occur. And so a pulmonary embolism, when it lodges like in that pulmonary branch right there, you're going to have immediate and rapid deterioration of your patient. So I will talk more about DVTs in cardiovascular, but a deep vein thrombosis, that is the most common reason why we get this. So again, it's usually going to result from some kind of dislodged clot or thrombus that most likely is going to occur in the leg veins, those big old leg veins. Your less common sources are going to be from the pelvic, the renal, the hepatic, and the arm veins, and the right side of the heart. Okay, so those are all things that you can see, where these are going to originate. Now, we will, when you guys get to the second part of med-surg, you guys will talk about musculoskeletal system. So an individual, especially with what we call a long bone fracture, like your femur, can actually have a fat embolus from a compound fracture. And for my OB people, amniotic fluid, okay? They can actually form clots during labor and delivery, and you will see where these young, healthy moms will throw a clot of amniotic fluid and it will become a pulmonary embolism. So anything that can clot and migrate can become a pulmonary embolism by landing in the pulmonary circulation. So our job as nurses, a lot of times, we want prevention, okay? And that's where a lot of our stuff comes from when we're looking at PEs, is we have to be looking at, well, who's high risk and how can we prevent this pulmonary embolus from happening? So this is why we walk our patients, okay? When I get to cardio very soon, I'm going to talk about that even our patients that we call fresh hearts, post-op CABG, they're up in the chair that night, okay? Because it's so important that we don't have patients that are sedentary and laying in bed and developing these blood clots. So we're going to get them up and move them. Once we determine that we have a deep vein thrombosis or a clot, we're going to do quick treatment. So for our high-risk patients, we're looking at warfarin or Coumadin, enoxaparin, that's Lovenox, and heparin. And I want you guys to really start looking at the medication lists of your patients when you're in clinic, and look how many patients that we have in the hospital on some form of blood thinner. Almost every single patient you see in the hospital is going to be on some kind of prevention for blood clots, because this is such a problem, and you certainly don't want to develop a PE if we can prevent it. So what does it look for, or what does it look like? Okay, well, total occlusion of that main pulmonary artery, like I said, is going to be rapidly fatal. your smaller or your fragmented emboli are going to produce symptoms that vary with the size, the number, and the location of the emboli. So dyspnea is going to be that first symptom of pulmonary embolism, and it may be accompanied by anginal or sharp pleuritic chest pain that worsens with inspiration. Some of your other clinical features that you're going to see, we'll see tachycardia, a productive cough. Their sputum may even be blood tinged. Every once in a while, you might see a low-grade fever. Your less common signs of, are going to include massive hemoptysis, like I said, splinting of the chest, leg edema. A large embolus may produce right-sided heart failure with cyanosis, syncope, distended jugular veins. Now, if this, progresses, you're going to see signs of shock, such as weak, rapid pulse and hypotension and hypoxia. And I know I've talked about this already. They're going to manifest with that restlessness. Okay, that's what that anxiety, hypoxia is going to look like. Cardiac auscultation usually will reveal a right ventricular third heart sound, which I'll talk about that more when we get to cardio. And then crackles and a pleural friction rub may even be heard directly over the infarction site. So test-wise, there's a lot of things that you can do. Sometimes you'll see a chest x-ray. An x-ray may also rule out pulmonary disease, may reveal areas of atelectasis. You could see an elevated diaphragm, a pleural effusion, and you can see what we call a prominent pulmonary artery or an enlarged pulmonary artery. The lung scan is going to show perfusion defects in areas beyond the occluded vessels. A normal lung scan will rule out a pulmonary embolism. And when I'm talking about a lung scan, I'm talking about nuclear medicine studies, also known as a VQ scan or a ventilation perfusion scan. A spiral CT scan or a spiral CT angiography, that will help visualize the embolus and the lungs. And that is what you're going to see most of the time that they do in the hospital. Spiral CT is an old term that we used to use. Now you're going to see them use like what they call a CT angiogram or a CTA of the chest, okay? Pulmonary angiography, that's going to be your most definitive test, but it poses a risk to the patient, such as an allergic reaction to the dye. You can have an infection at the catheter site because we have to put it in with an IV, and kidney failure related to difficulty excreting the dye. And that's something that anytime you see the word angio, that means we're using dye in it, okay? And there's always that potential for, them having that allergic reaction, or you can have an acute kidney failure related to it. So you have to be very, very careful when we use dye. It's going to be dependent on the uncertainty of the diagnosis and the need to avoid unnecessary anticoagulant therapy for your high-risk patients. I don't have this on here, but an EKG or an ECG would sometimes be utilized. It's inconclusive, but it will help you distinguish a pulmonary embolism from a myocardial infarction. So that's why they would actually do that instead. ABG, again, didn't have that on here either. These are going to show you your partial pressure of oxygen, your partial pressure of CO2, especially with that ventilation perfusion mismatch. We may want to look at an ABG and see what we're looking at. Now, D-dimer, I talk a lot about D-dimer and how I think sometimes it's not a very efficient lab test. It will be elevated because it indicates the presence of a blood clot in the body, and it strongly suggests a pulmonary embolism. The problem I have with the D-dimer, though, is it takes way too long to get your results back. And if you truly, truly believe that your patient has a blood clot, you should go ahead and order the scan instead rather than waiting the 60 to 90 minutes on a D-dimer. But that's my soapbox on D-dimers. So treatment is going to be aimed at maintaining adequate cardiovascular and pulmonary function as the obstruction resolves and to prevent recurrence of it, okay? Because most emboli resolve within 10 days, treatment is going to consist of oxygen therapy as needed and anticoagulation with heparin to inhibit new thrombus formation. So patients with massive pulmonary embolism and shock may require thrombolytic therapy with something we call tissue plasminogen activator or TPA. And you guys will talk about that in pharmacology a little bit more. Big ones we see are going to be like alteplase, for example, and it enhances the fibrinolysis of the pulmonary embolus and the remaining thrombi. Hypotension related to the pulmonary emboli may be treated with a medication that we use called vasopressors, known more commonly as like epinephrine, for example. Surgery to interrupt the inferior vena cava is going to be reserved for patients for whom the anticoagulants are contraindicated. So people that are elderly, patients who have had recent surgery, or who have clotting problems particularly, they will go in and have what they call an embolectomy done, where they actually go in and remove itself. Surgery can also consist of something called a vena cava ligation, um, or they can insert an umbrella filter, okay, which is what I'm talking about here, a jugular or a femoral filter, um, for blood returning to the heart and to the lungs. The patient can receive a combination of low dose heparin, low molecular weight heparin or Lovenox to prevent any post-op venous thromboembolisms. So, because with a pulmonary embolism, we're looking at a very rapid deterioration of the patient. Here's some of the things that we definitely want to make sure that we do for them. We're going to give oxygen, okay? So, that could be by nasal cannula, it could be by a mask. We're going to check those ABG levels, okay? Especially if we have, new onset dyspnea. We want to be prepared to provide equipment for an endotracheal intubation and assist with ventilation if breathing is going to be severely compromised. If necessary, you want to prepare to transfer this patient to an ICU setting according to the facility policy. We're going to administer heparin as ordered through a continuous drip. We're going to monitor coagulation studies daily and after changes in heparin dosage. So when we give heparin, the big lab that we're going to be looking at is a PTT. Okay, that's the lab we're going to monitor. We want to make sure that we maintain adequate hydration to avoid the risk of hypercoagulopathies. After the patient is stable, you're going to encourage the patient to move around and assist with their own range of motion exercises. You check the patient's temperature and the color of their feet to detect anything like venostasis. You're never going to vigorously massage the patient's legs. And again, we'll talk about that more in cardio. We walk the patient as soon as possible after surgery. We're going to report any frequent pleuritic chest pain so that analgesics can be prescribed. And we're going to continually evaluate our patients. So we're going to watch the vital signs. They should be within those normal ranges. And we want to have, we want to check the patient for any signs of bleeding, especially when we're on anticoagulant therapy. So these are all things that we're going to watch for after we have successfully helped our patient with the PE. Nursing diagnoses for these patients, impaired gas exchange is a great one. Risk for injury related to anticoagulant use. So as we move into cardio, I'm going to talk a lot more about safety in terms to patients on anticoagulants. All right, and that is going to wrap up the lecture on PE.